Alright, so continuing with the topics in the pediatric orthopedic, next very relevant topic out of which multiple questions are being asked today, and that relevant topic is CTEV, that is congenital talipes equinovarus. So first of all, let's have a discussion on the heading itself and what all is relevant for you to remember before coming to the identification point. So CTEV, the next topic is CTEV. So what is the full form? It is congenital talipes equinovarus. So if you break this term, that is CTEV, that means congenital talipes equinovarus. If you break the term, then congenital means since birth. All of you are aware of this. Tali means the ankle, because talus is the major component of the ankle joint. So tali is representing the ankle joint. Equinus is one such deformity. You will come to know what exactly is equinus. So equinus is the deformity which is happening principally at the level of talar joint, or that means ankle joint. So tali is related to the equinus. Pes is the word which is used for foot. So pes actually is the foot, and varus is the combination of the deformity which is happening at the level of foot. That means pes. So this is the reason why it is called as congenital talipes equinovarus. So first of all, the thing that you came to know about, that this deformity is congenitally present. That means since birth this deformity is present. So first of all, point number one that is important for us to understand is that it is the most common congenital defect in orthopedics. You know, it is said that at least 1 in 1,000 live birth is suffering from either a permanent sort of a deformity or some sort of a CTEV deformity. So this is considered to be the most common congenital abnormality in orthopedics. Point number one. Now point number two, what are considered to be the causes for this CTEV deformity? As far as causes are concerned, the idiopathic is considered to be the most common cause. So idiopathic is the most common one. Now there are certain other syndromes with which this CTEV could be associated. Like it is found to be associated with Down syndrome, as well as it is found to be associated with Larsen syndrome. You know, the thing is, then when this CTEV deformity is found to be associated with some of the syndromes like Down and Larsen, it is having relatively good prognosis. Alright, that means the treatment of this CTEV is easier. But if the same CTEV deformity is present with any other syndromic abnormality like arthrogryposis or meningocele, you know, if the CTEV deformity is associated with these conditions, then it would be having a poor prognostic outcome. So it will be having poor prognosis. Now, having dealt with the discussion of the causes and a congenital presence, now it is important for us to identify the CTEV deformity, or how on the basis of the picture itself which is provided to you in the examination, you will be able to diagnose that is it CTEV or not, because CTEV is clinically diagnosed condition. By the time the child is born, just by looking at the abnormalities of the foot, you can diagnose the condition, or you can label the condition as CTEV. So in order to make the diagnosis, all you need to have a basic understanding of the deformities. So next topic under the heading of CTEV are the deformities in CTEV. Now the first number deformity is equinus. Now all of you know what the equinus is. You know, it is the fixed plantar flexion. The two possible movement at the level of foot, one is dorsiflexion, other one is plantar flexion. So when the child is born with the fixed plantar flexion, all right, it is known as equinus deformity. Equinus is fixed plantar flexion, and this fixed plantar flexion, because you know the plantar flexion and dorsiflexion of the ankle, it is happening at the level of talar joint. That means the proper ankle joint. So this is the deformity which is happening at the level of ankle joint, fixed plantar flexion deformity. Now some of you might be wondering that why is it known by the name of equinus? Because equine is the word which is used in context or in relation to horses. You know, in case of a horse, the long axis of the leg is almost aligned to the long axis of the foot, while in case of human being, long axis of the leg is perpendicular to the long axis of the foot. So what happens if there is a plantar flexion deformity? Then the long axis of the foot will be more or less aligned to the long axis of the leg. That means it will be more or less become similar to that to the finding which is present in case of horses. That is the reason why it is called by the name of equinus deformity. So equinus is the fixed plantar flexion at the level of ankle, and it is one of the major component of the CTEV. The second one is inversion. You know, the two possible movement at the level of foot is inversion and eversion. Inversion is when the plantar surface of the great toe is facing towards the midline. That is inversion. While eversion is when the plantar surface of the foot is facing laterally. That is eversion of the foot. So what happens in CTEV? There is an inversion deformity. And you know, this inversion and eversion of the foot is not happening at the level of ankle joint. It is happening at the level of subtalar joint. So this is the deformity at subtalar joint. That means talocalcaneal joint. Then point number 3. The third deformity is forefoot adduction. You know what happens in forefoot adduction? That, you know, if the foot is divided into anterior, middle and posterior, that means forefoot, midfoot and hindfoot, then the anterior most part of the foot is adducted medially. So it will be called as forefoot adduction. So this is one such deformity. Apart from this, there will be cavus. Now what is cavus deformity? Just try to understand. You know, the normal surface of the foot is not, or the plantar surface of the foot is not flat. It is having a concavity. Now this concavity is present on the medial side. This is represented by medial plantar arch. Now imagine, if a patient is having a equinus deformity, inversion deformity, as well as forefoot adduction, then this entire plantar arch would be converted into a deep medial crease of the foot, and that is what is known by the name of cavum. Alright, so cavus is the deep skin crease over plantar aspect on medial surface of the foot. Alright, so that is known as cavus deformity, or this is known by the name of cavus deformity. And finally, there will be internal rotation of the tibia. Internal rotation of tibia. So these are the principal deformities of the CTEV. The first one is equinus, then there will be inversion, then there will be forefoot adduction, there will be cavum, and there will be internal rotation of the tibia. Now imagine, keeping all these deformities in your mind, would you be able to diagnose, would you be able to identify a CTEV deformity? Yes or no? Obviously yes, you will be able to identify it. Imagine if a child is born where the foot is in equinus, it is in inversion, it is in forefoot adduction, and to some extent there will be a deep skin crease present on the medial aspect of the foot. It is diagnosed clinically as CTEV deformity, and this is how you can identify it in this picture itself. That here what all you can get is that to some extent it is in equinus, although this is the AP view, but yes, forefoot adduction is clearly visible, inversion of the foot is clearly visible. On the basis of these deformities, on the basis of these findings, you can mark the diagnosis of CTEV. So this is how CTEV is diagnosed clinically. That is point number 3. So what all we have discussed in CTEV, point number 1 was that it is a congenital abnormality, which is the most common abnormality in the orthopedic practice. Point number 2, that what are the causes related to the CTEV? Most commonly it is idiopathic without any reason. Point number 3, the identification of the deformities. That means what all are the deformities which are present in the CTEV. Next comes the point number 4. And the 4th point is definitely related with the management. That means treatment of the CTEV. You know, recently they have asked multiple of the questions related to the management, because when it comes to CTEV, the two things which an examiner expects from you, one thing is the identification of the CTEV deformity, and the second one is the treatment. That means management part of the CTEV deformity. So as far as the treatment or the management of the CTEV deformity is concerned, it is in case of a newborn is something that you have to remember. Alright. So treatment in case of a newborn, because you know there could be a different age group the patient could be coming to you. He might come in the age group of a newborn. That means immediately after getting, imagine the child is born immediately and the deformity is clearly noticeable. So the parents will come to you that how to manage this condition. Second is, at certain age groups the patient might come to you. The reasons for those later appearances of the patient, 1 is neglection, 2 is recurrence of the deformity. All right, that there was a recurrence of the deformity. Initially it got corrected, but now it is getting recurrent. So first let's talk about the management in case of a newborn. Now, in case of a newborn, there are two methods for the management of the CTEV deformity, and these two methods are the Kite's method and the Ponseti method. Now, out of the two, first of all, before we talk anything related to these two methods, out of the two, which one is clinically practiced today or which one is preferred today? It is the Ponseti method which is preferred today. So, Ponseti is the preferred method. Alright, out of the two. Now, why Ponseti is preferred? In order to understand that distinction or that why Ponseti is given a weightage over Kite's method in order to manage this condition, first of all, let's have a distinguishing feature in between these two. That in case of a Kite's method, you know, the first cast application, that means first cast is applied at 3 months of age. While in case of Ponseti method, the first cast is applied as early as possible, as soon as possible. Similarly, in case of Kite's method, there is an order of correction of deformity. First of all, you write it down. After that, you will be able to understand that what is the significance of this order as well as the timing of first cast application. Order of correction of the deformity. Now, order of correction of deformity in case of Kite's method is cavus has to be corrected first, then forefoot adduction has to be corrected next, then varus has to be corrected next, and then equinus. Alright, so this is the order of correction of the deformity, that cavus, forefoot adduction, then varus, that means inversion, and then finally the equinus deformity has to be corrected. So this is the order that you have to follow in case of Kite's method. While in case of Ponseti method, there is no such order that is meant to be followed. In case of Ponseti method, what you do, that cavus is corrected first, yes, no doubt, where the cast is applied in supination of the foot. You actually supine the foot in more deformed position, alright, and then apply the cast. But cavus is corrected first, and then subsequently, there will be a simultaneous correction of all the deformities. Simultaneous correction of all deformities. Alright, so this is all what you need to remember in between the two. That is the basic difference. Now let's have a discussion on that what is the meaning of this term. That means the timing of the first cast application, or what is the cast application. Actually, the treatment of CTEV in case of a newborn is achieved by serial correction of deformities by above knee casts. Now, all of you are aware of what exactly the cast is. Cast, you know, there is a circumferential enclosure of the entire limb, or the limb that has to be corrected within the plaster of Paris, circumferential enclosure. So that is the cast application. So serial correction of all the deformities means that gradually you correct all the deformities and enclose it inside the cast. And that cast is applied for the duration of around 7 days. Alright, so that is serial correction of all the deformity by the application of the above elbow cast. Now for that we have got the two methods. One is Kite method, other one is Ponseti method. In case of Kite method, what is the first cast, or when the first cast is applied? You know, first cast is applied at 3 months of age. Then you will ask, why not the first cast is applied? Why not we correct all the deformity immediately after birth? Because in case of Kite method, it was preferred not to apply the cast immediately after birth. Rather, you ask the mother to manipulate the foot while feeding the baby. Alright. So in this 3 months duration of time, what was advised? It was advised that you have to manipulate the foot by mother. Means mother was treated, or mother was explained how to manipulate the foot in the corrective position up to 3 months of age. Then when the child will become 3 months of age, we will treat the condition by the application of the cast. That is the difference. While in case of Ponseti method, what is happening? You are not waiting for 3 months.